The topic here today, this morning's series of discussions, has laid out the science very well for the biomarkers and pathways. And so really what I want to do is sort of make rubber hit the road. What does it matter? How can we apply these things clinically? And if you look at the current scenario with regard to screening, we have a plethora of resources. We have many, many markers. And, it's a lot like, I would say the woman, but I'll say the person standing in front of their closet trying to decide what outfit to wear and spending, the next 45 minutes trying to make that decision. I'm not saying I've ever seen that at my house, but if I had, I would see the confusion. Or for those of you, being from the South, if you have multiple targets in a hunting situation, it's hard to figure out which target to acquire first. And so that's where we are with this. And the solution that I'll give you is that it's best just to try to define something with which you are comfortable. Get to know that to the best of your ability so that you can practice that to the best of your patient's outcome. I would like to say about informed decision-making that Dr. Crawford pointed out, you're absolutely right. In primary care and the rest of medicine, nobody's mandated to have these shared decision-making conversations with patients. That doesn't mean it's the wrong thing for us to do sometimes. I think there is definitely an occasion for shared decision-making. But the thing that I put out there, and this has taken me a long time to get to this conclusion, and this is just my personal thought, but informed decision-making cannot predefine the outcome. And I'll say that again. You cannot presuppose to know what the decision is prior to embarking on that conversation. Otherwise, you're not having a fair conversation with your patient. And to unpack it a little further, if I think I know what's best, and maybe I do think I know what's best, but I cannot have my mind completely made up until I've listened to my patient and to what is important to them. So it really has to be a malleable process with an open mind for it to be effective. So what I decided to do to try to put all of these statistics together, if you will, is just walk through a patient. And a few months ago, I had a patient who really hit every one of these tests, as you'll see. And I want to spark a little controversy, hopefully, generate some questions for us to tackle at the panel session. But this is a patient who's 54 years old, has had symptomatic BPH. Both his father and his grandfather died of prostate cancer. Most of the time today, we don't have that. I mean, the patient will say, well, my grandfather died. We don't know what that was from. But this fellow's grandfather died recently enough in the past that it was defined to be from prostate cancer. The most challenging aspect of this fellow's case is that his wife is really special. She's very attentive and really has unlimited time available for research. And I think you understand what I'm saying there. So he comes to me having been on Flomax for a couple of years. His PSA's been less than 0.5. So his PCP listened to Dr. Crawford's paradigm that PSA 1.5 is the new 4. His PCP was paying attention to that. And when the PSA came to be 1.5, he referred him on. He had examined the patient, something that I don't see that often in our primary care world, so hats off to him for actually doing a rectal exam. And on exam, I agree that he had a benign exam. So he's got a PSA that's come up with significant velocity. He's come up to that level now that we agree 1.5 might have some meaning in a 54-year-old. And so the options that we discussed are, as you see and as you've heard already this morning, and I think you'll hear in the subsequent 3 talks, we're really going to go through this in an iterative fashion this morning. So, and there may be other options that I have not included. So what he decided to do at that point was a biopsy. So he had a 12-course standard biopsy, and it was negative for malignancy, but at one area of the prostate, 2 cores, both in the left base and left lateral base, which is how we map that, he had ASAP. So wife wasn't satisfied with just stopping and resuming screening at this point. So what do? How do we use these biomarkers in front of us to go on? So we sent the negative biopsy off, as Dr. Crawford put forth, for a confirmed MDX, and this came back completely negative on all 3 genes in every area. And I will say, and I'll touch on this a little bit later, having the map that confirmed MDX brings you of the prostate where the methylation may be positive, I think is a really important tool to overlay with your multiparametric MRI so that you can look at the gene abnormalities, because obviously this is just totally anecdotal, but taking that information back to the radiologist may change his opinion on his reading in a given area, which highlights what Dr. Lynn spoke to, and that's the variability of MRI. And hopefully in the near future, maybe not the near future, but in the future, machine learning and artificial intelligence may take some of that reader variability out of MRI reading and making it more consistent. For that matter, may do the same with pathology reports. We're not there yet. So after he had a negative methylation, wife still wasn't satisfied. She wanted more. So we discussed, okay, well, here's more options we can keep doing. And we also had that informed decision making that, we can keep doing this ad infinitum. Are you ever going to be satisfied? And she sort of scratched her head and wasn't sure the answer at that point. So at this point, we did decide to go ahead with a 4K score. So we have a negative methylation, but the 4K score comes back with a 30% chance of a significant cancer. So we've got some conflicting information. And I think this is the real take-home of this whole morning, is that we don't have a perfect situation, and there are many times when seemingly good, statistically sound information contradicts. So what's next? We've got a 30% chance of significant cancer flying in the face of a negative systematic biopsy and of a negative confirmed MDX. So as you could guess, we're not going to stop at this point. So we went on to a multiparametric MRI. And, yesterday's talks highlighted the precision and the promise trials. Dr. Shore did a nice job of unpacking that. And I will say that about a year ago, after roughly a year of having multiparametric MRIs rejected and sent to peer review by Blue Cross of Louisiana, we took the precision paper to the medical director and said, look at your history of overturning your denials. Basically, there's almost 100% passage through once we've gone to peer-to-peer of an MRI for this patient. I said, and this is even in the pre-first biopsy state. And so what they agreed to do was embark on a 1-year project where they would look at all of the MRIs we ordered, at the outcome of peer-to-peer reviews, and at the outcome of what the MRI did to change our decision-making process. And I can tell you, as of 2 months ago, Blue Cross of Louisiana granted our group the ability to order the multiparametric MRI on biopsy-naive patients based on that data. So we're able to actually put the precision trial to use, and that is how we use that in our practice. Not uniformly, but at least it is an option that we don't have to worry about bureaucratic pushback clouding the waters there. So in this patient, to recap, he's got that 30% chance on a 4K score. We got the multiparametric MRI. We do have a radiologist who's used MRI now for over 8 years. He's read over 3,000 studies. So I think we've got a good user on that end of the stick. And we have a nice 3T Phillips magnet. So we had 2 PI-RADS3 lesions, one in the same area, incidentally, where the ASAP was found on biopsy, and one across the gland and to the anterior area. So what did you think we're going to do at this point? Well, obviously, we're going to have to proceed to a fusion biopsy. So in our institution, fusion biopsy includes a standard template as well as the fusion. I think the data is very controversial on whether or not you need to. At this point, I think you missed too many with going straight fusion. So his fusion biopsy results still had ASAP consistently in the left base. Interestingly enough, we added a finding of ASAP in the right target gland. So now we've got bilateral ASAP, but still no cancer. We repeated a confirmed MDX just to see if this tissue for whatever reason, might show a difference in the hypermethylation. And that is, again, anecdotal. There's no, that I know of, scientific background for changing outcomes on repeated tests. It was, again, negative. So we're piling up this massive data about what to do with this, and this massive bills too, about what to do with this one patient. And again, he's 54 years old, very healthy, other than his neurosis, so which we're just compounding at this point. So at this point, what would the next step be? I think the next step's a little bit of a wild card, and that's where the wife came in and said, I want somebody else to look at this pathology report. That wasn't one of the biomarkers that I was going to include in this. But nevertheless, we sent this out and to a nationally known institution, and he comes back with Gleason's grade group 1 in the right target gland. So how's that for a wild card? I'd like to tell you that at this point our shared decision-making came to some conclusive rest where everybody has a peaceful state of mind. That's not the case. So in a month, this gentleman who's 54, I think he's turned 55 this upcoming month, will have a robotic prostatectomy. And it'll be interesting to know what the final pathology shows. It goes back to a question Dr. Crawford generated, and that is that, in the select MDX patient negative biopsies, there were no high-grade cancers that were missed. But do we know that same to be true for the radical prostatectomy specimens? And so this is in an N of 1, we might learn that with this patient. So to sum it up, we have many resources. They're all statistically valid. They're all very sound tests. They unfortunately do not provide us with a straight pathway on which to use, when to use it, and why to use it. And again, in my practice, I think the most sound advice I can give, in addition to having that true, open-minded, shared decision-making and educational process, is to find one process that fits for you best. It's a lot like back 30 years ago when they said you're only going to prescribe 3 drugs as a urologist. You're going to pick your 3 drugs, and those are your go-to drugs, right? And back then it was basically Hytrin and Cipro, and I forget the third one. But that's the same place we are now with these biomarkers. You're going to have a few that you're comfortable with. You're going to know what it means to you. You're going to find those nuances, given that they're anecdotal nuances that you'll employ in your own practice, but they will work for you and your patients. And so that's, at this point, what we have is no further clarity, muddied the water a little bit, hopefully generate some good controversy for our Q&A session.